We on?
Give it one quick
We are.
second.
It says we're streaming.
All right, and we're live.
Thank you. Welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who is not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witness timing. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear the timer ring. There will be a timer, you'll see it in the corner of your screen, or at least in the corner of Melissa's picture. Please conclude your remarks when you hear the timer ring. Members must remain present with your video camera on during the entirety of the hearing. Members, please ask only one question of one witness. If you have other questions, you may follow up offline. Please use the raised hand function to indicate that you have a question. And with that, the first hearing of the day will be on House Bill 119. Delegate Sample Hughes, are you there and ready to go?
Yes, ma'am, I am. And good afternoon.
Oh, good. Hi, welcome.
Thank you. Good afternoon, all. And thank you, Madam Chair and members of HGO Committee. Today, I am pleased to introduce House Bill 119, Maryland Department of Public Health Outreach Programs, Cognitive Impairment, and Alzheimer's Disease. I ask for your support of this bill, which would mandate that the Department of Health, in partnership with the Department of Aging, the Virginia I. Jones Alzheimer's Disease and Related Disorders Council, and the Alzheimer's Association begin to incorporating messaging about Alzheimer's and related dementia into its relevant public outreach programs, which work with providers and mailers statewide. This legislation has many important provisions, including improved outreach to providers, but I want to focus my comments today on its potential to improve health disparities overall. Alzheimer's and related dementia is a disease that African Americans are twice as likely to have as Caucasians, and Latinos are 1.5 times as likely to have than Caucasians. This legislation makes it clear that a priority of the General Assembly is the reduction of Alzheimer's and related dementia, specifically among communities that are more at risk of these disease and generally neglected. We know we have a health department which is a trusted source of information, and their relevant outreach programs would help to reduce the inconsistencies in the messaging, but also strengthen the message to these very same communities. So I have taken this bill on for certainly personal reasons, because my mother has been stricken with Alzheimer's and dementia, but moreover, the goal is, and it will always be, is to ensure that citizens of Maryland are aware, they're equipped with any type of knowledge that they can receive from a trusted source, such as the health department, and get that information on the ground to those specific caregivers and beyond. So this bill received a favorable vote from our committee last year. It passed out the House unanimously, but unfortunately was not heard in the Senate due to the pandemic. Again, I would like to thank you for hearing this bill, and I urge a favorable report on House Bill 119. Thank you, Madam Chair.
I noticed that all the testimony is in support of the bill. No one is opposed. Does anyone have any questions? I see no hands. That being the case, House Bill 119, the hearing is finished, and we will now proceed to House Bill 393. And I think that's also Delegate Sample Hughes. Oops, no, it's not. Let's try again. Let me see if I can find the other, there it is. We're going to go to House Bill 141. Delegate Sample Hughes, so you can do both of your bills
Sure.
in series. There you go.
Okay, and we do have witnesses on this bill. I can't tell if they're on or not, but I'm sure Melissa knows whether or not they're on. So I will go ahead and begin my testimony and look forward to the meeting. So again, good afternoon, Chairman Pendergrass and our Vice Chair. Today I have before you House Bill 141, Maryland Department of Health Residential Service Agencies Training Requirements, which would mandate that residential service agencies in Maryland provide direct care and administrative care staff with 3 hours of initial related training to dementia care, and then have 2 hours of continuing education for staff every year. Again, as someone who has and is a care provider for a patient, my mother, that grapples with dementia, this bill is certainly important, and I've seen and heard from constituents and citizens throughout the state of Maryland of how they want to ensure that whomever is taking care of their loved one is properly trained, especially when they seek out the services of a residential service agency. This legislation came to me 3 years ago from a constituent and actually a residential service agency owner by the name of Amy Keller, who you will hear from on today. She will definitely go into the details of how the industry was growing increasingly concerned of the mere fact that the challenges and the individuals that unfortunately are grappling with dementia and related source issues, the age group is getting younger and younger and younger, but yet the staff are not having proper training. She came to me in addition to her verbal concerns, but she came to me with a huge binder, the largest binder I think I've ever seen from an advocate or from someone that wanted to ensure that pieces of legislation would move through. But within this binder, it had color-coded pieces of legislation and COMAR references and PowerPoints and studies, but more importantly, it had a curriculum that dealt specifically with dementia, and one that she was able to infuse into her residential service agency so the employees would be properly trained. So since then, I've worked diligently with the Alzheimer's Association of Maryland, the Maryland National Capital Home Care Association to create this bill so we can protect the employees and protect the industry in of itself. And now today we are side by side on this piece of legislation, meaning that we have worked through the interim and we are on the same accord that it is important to have this training to our care providers, given the fact that our care providers make up about 37% that are on public assistance. Those individuals, some lack health care and insurance themselves, and their income is not that great. But my point is that they're doing this on the ground work with our loved ones in our homes, but not properly trained. I want to bring to your attention that there are 2 items. One in particular, there is a technical amendment that you have before you. I want to share with you that the technical amendment is to clearly define that if you are a employee and you have received your 3 hours worth of training, that annual training, and you move to another agency, that you're not required to take it again, because that would be duplication of services. And that training, you've already met that requirement and you're good to move to the next agency with that particular training. So that is a technical amendment to just clarify. The last piece I want to share with you is that I did receive a letter of information from the Department of Health, and it is somewhat inconclusive. And not only I say it's inconclusive, but also the report that you have before you from the DLS has warranted and made the same statement that I have as well. And the statement reads as thus: the Department of Legislative Services did not receive sufficient information from MDH in a time to fully analyze this estimate. However, the estimate seems to overstate the impact on rates, as it is consistent with an estimate for previous legislation that required double the amount of training. Thus, Medicaid expenditures increased by an indeterminate amount. and fiscal 2023 and subsequent years to comply with additional training requirements under this bill. My point is this, is that yes, it has a fiscal note, and it appears that it is at 25 cents per hour that these individuals would have this training of an increase. However, we don't have enough information from the Department of Health. As I shared with you, and as DLS's report, the fiscal note states the exact same. So we're at a pivotal point that we know and need the training. I hope that I receive a favorable report on this from this committee, but I want to urge you that we need to fill this critical gap, and we need to ensure that this piece of legislation, House Bill 141, has a favorable report, but with the understanding that a little bit more information is needed from Department of Health so we can clearly understand and move forward. Thank you for your time, and the witnesses will share additional information. Thank you, Madam Chair.
Thank you very much. It was great explanation of the bill. I'm going to take the first witness will be David Rodwin. Are you with us here?
All of the witnesses should be in the room now.
David Rodman, it's your turn.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is David Rodwin. I'm an attorney at the Public Justice Center, which is a nonprofit public interest legal organization in Maryland, where I advocate for workers and in particular for home care workers. It's an honor and a pleasure to be with you here today. I'm also the Vice Chair of the board of the Maryland Regional Direct Services Collaborative, which is dedicated to bringing people and organizations together to work towards building and sustaining a well-trained direct care workforce to meet our state's growing need for it. The Public Justice Center supports this bill, HB 141. We absolutely need to invest in the direct care workforce, and especially in the home care workers that are the subject of this bill. Dementia training is vital, and it involves caring for people with dementia involves particular skills that, as of now, workers are not necessarily trained in. And lack of training is one of the reasons why our state does not have enough home care workers to meet our growing need. This bill alone won't fully solve the problem of the worker shortage, but it will provide a critically important investment in this workforce, one that is sorely needed. So BJC supports this bill, and I think it says a lot, just as a general note, as Delegate Sample Hughes mentions, that there are folks from so many different stakeholder organizations here today supporting it. And so it's my pleasure on behalf of the Public Justice Center to urge a favorable report for the bill. Thank you very much.
Thank you very much. I think we're going to wait and hold our questions till we hear from all of the support witnesses. I'm going to take Evie Vandermeer next.
Okay, thank you. I was thinking you were unmuting me, but I got to do it myself. Hi, I'm Evie Vandermeer, and I'm here in support of HB 141. My husband, Mark, was diagnosed at age 61 with young onset Alzheimer's disease. In the first couple of years, I believed that I'd be able to care for Mark until his death. I could not have imagined the toll that it would take on me. Every daily task required problem solving. How do I get him to eat, sit in the car, find the toilet, or stay calm throughout the day? What do I do when he bolts out the front door and runs down the street, or insists on walking the dog by himself? It's draining to argue, to say no, and to ride through the neighborhood looking for him, or even to call the police. Eventually, my friends and family began insisting that I hire a residential service agency. They recognized that I was barely getting through a day. So I finally acquiesced, knowing that there was still a very long journey ahead of me. I panicked when I discovered that a hired caregiver does not have training in dementia. I knew that there was no hope for me to get relief and recovery time if someone came in thinking that they could bring a book, watch TV, or even just prepare a lunch. I wouldn't need a break if it was that simple. I was determined that I'd find a way to recover my coping skills. My solution was to stay home with the carers for the first 3 visits. I asked them to observe how I interacted with Mark, how he reacted, and how to respond with a calm and positive, loving voice. In other words, I paid for the training of 3 women and gave up those hours of recovery and refreshment for myself. I did it because it was the only way I could think of to prevent myself from crashing. People who care for their loved ones with dementia are living with high levels of anxiety and trauma. A great majority are sleep deprived, bombarded with confusing and repetitive conversations, battle weary over eating, hygiene, and aggressive behaviors. Now imagine living with this level of trauma for years. It is not sustainable. Training in dementia care for home care agencies can no longer be optional. Without it, the trauma of those living in a house with dementia behaviors exponentially crushes the lives of the living and the dying. Our healthcare systems will also be further crushed. Please support this bill, which requires residential service agencies to provide training in dementia care. Thank you for your time.
Thank you very much. We appreciate your personal experience.
Thank you.
Eric Colchamaro.
Chair Pendergrass and Vice Chair Pena-Melnick. My name is Eric Colchamaro, and I'm the Director of Government Affairs for the Alzheimer's Association in Maryland. Thank you for the opportunity to offer testimony about this legislation. You have my written testimony before you, so I will only cover a few key points within it. Dementia-specific training is essential for providing quality care to Marylanders with Alzheimer's disease and other forms of dementia. Individuals with Alzheimer's or other forms of dementia have specific needs, including the 95% of them who have at least one other chronic condition which complicates their care. This bill sets a vital baseline to train Maryland's RSA direct care staff and supervisors who work with individuals with Alzheimer's or other dementia. It allows time for the training to be developed, and then beginning in July of 2022, requires at least 3 hours of initial training and 2 hours of annual continuing education training for staff and for supervisors. It recognizes the logistical and financial concerns of providers and allows the training to be provided online or by an appropriate supervisory staff member. It also notes that if a trained individual changes home care employer, they have the option to not have to complete the training at a new organization, as long as they have done the training recently and have sustained dementia direct care or supervisory work. Lastly, as the Speaker Pro Tem mentioned, there is a small clarifying amendment saying that they can do the training. I want to close by thanking the Speaker Pro Tem and the Maryland National Capital Home Care Association and the vast majority of home care providers they represent for their support of this legislation. I particularly appreciate Dawn Seek, their executive director, who serves on the Maryland State Alzheimer's Disease and Related Disorders Council, along with Dawn's membership, who employ a workforce essential to Maryland before, during, and after the COVID-19 pandemic. I urge a favorable report on this legislation.
Thank you very much, Eric. No, we're saving questions. Dana Kaufman, you're favorable with amendment.
Yes. Thank you very much. For the record, my name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise, and I'm here on behalf of the Maryland National Capital Home Care Association. The amendment that I referenced in my testimony, my written testimony, is actually the amendment that is being brought forward by the sponsor. I'm pleased to say that after many years, the Maryland National Capital Home Care Association is supportive of House Bill 141. We were always supportive of the intent, and we understand the need to have additional training for Alzheimer's and dementia care for our employees. The issue was more of the best way to actually incorporate that into the operations. We believe that this bill does strike a very good balance between the need to provide care as well as the flexibility needed for providers, especially as they continue to battle the COVID-19 pandemic. So with that, we request a favorable vote with the amendment offered by the sponsor. Thank you.
Great. Thank you so much for clarifying that. I really do appreciate it. I was hoping that's what you were going to say, but
Yes.
that's actually why you were a little out of order in the speaking from the sign-up sheet. Now here comes the technical difficulty. Melissa, did you get my text
Yes, I
on
did.
your phone?
Mhm.
And did something go wrong so that's not happening today?
No, we have Amy Keller speaking next.
We have Amy Keller.
Hi, I wanted to, my name's
Okay.
Amy Keller. I am a certified dementia trainer. As long as I own Aging at Home Solutions in Easton, Maryland. I am a residential service agency. One of the things when I did meet with Delegate Sample Hughes, it was very frustrating to me to realize when I was going through everything to be prepared to open my company, that there was no requirement for any type of dementia training. We are simply setting our caregivers up to fail, because if they go into a home and don't have the proper training, they're going to turn around and leave or not come back. So hence our turnover rate continues to go up in this industry. I believe that we do need to have a standard for this company, this industry. I do recommend, and I agree, that 3 hours training to better support our seniors. I just want to say a couple of things. I know I sent a letter in, but this used to be considered a cottage industry 20 years ago. It wasn't really known. In 2018, it was a $260 billion industry. They're projecting for 2026, a $482 billion industry. We really need to support the caregivers, the families, and the staff. Thank you for your time.
Thank you very much. Now I'm going to look and see if there are any hands raised to see if we have any questions. Delegate Kelly.
Thank you, Madam Chairman, and thank you, Delegate Sample Hughes, for this bill. I think I, like many members of the committee, have a lot of personal experience in this space. My father has dementia, my aunt, 2 of my 4 grandparents. So I know how difficult this is, and I am very appreciative of this idea that we would be investing in this workforce. Really want to thank the industry for coming to the table and making some difficult compromises. I applaud them for doing that. My question is specifically related to what Delegate Sample Hughes raised, which was the fiscal note. So, you know, it's clear that the 25 cents per hour that would be the increase, it's clear from the fiscal note that we don't think that that is accurate. If the training is cut in half from last year's bill, do we think that it's fair that the cost would be roughly half of that, 12.5 cents per hour? Do we have any sense? And what's the plan for getting that information? I know it's not been easy, so I'm wondering if we can help figure that out.
Hi, Delegate Kelly. I can start with a response here, and then I welcome any comments. Dana.
There will be one response for one question, so choose your best responder, please.
Very good. I can field that one, and thank you for the guidance, Chair.
Sure.
I would say the 25 cent cost is wrong. Quite simply, and that's part of the reason why DLS questioned it. The actual cost would be, I would estimate, even less than half. Specifically, as noted, the number of training hours has been significantly addressed. In addition, the the 25% analysis doesn't take into consideration that the scope of the training has changed in terms of the topic areas covered from last year's legislation. In addition, it does not address that we've provided more flexibility and in turn, hopefully a reduced cost to providers in allowing supervisors to provide the training, and in addition, allowing the training to be provided online. Lastly, I would just add that a significant number of home care providers do not accept Medicaid, so a Medicaid rate adjustment and a correct analysis should factor in that, and it's unclear as to whether the health department fully took that into consideration.
Thank you very much.
Okay, and I see Delegate Krebs, you're next, followed by Delegate Lewis-Young.
Thank you. Maybe Dana can offer this. First of all, thank you for the bill. I think it's definitely something that we need to look at. But can you explain to me what is the current training for these folks now? And are there any opportunities to revamp what are, I mean, I don't know what they even need to get in to do this job. So can you explain what they have to do currently?
The COMAR regs do require a set of training that needs to take place before that they can do direct care. And then that has to be signed off by the supervisor before they can be able to work independently. I can get you the list of items now that have to be that are part of that training.
So would this be included in that? This would be part of that. I mean, this isn't going to be COMAR. I mean, how are we going to, I guess I'm trying to figure out how this would be part of the current training, just be in addition to it, like we're improving the training.
It would be in addition to, so there are similar training requirements for assisted living as well as nursing homes. And it's within the first 45 days of employment. So typically that training is done, well, it was nice, and we appreciate the sponsor working with us because it does allow the supervisor to provide that training. And frankly, that's probably one of the best opportunities for training is that hands-on care. But it can also be coupled, and some do. You know, every RSA does it a little bit different. Some will actually bring in an outside training entity and will have days for different training episodes in their central office. Some will have their supervisors do it. So it really just really does depend on the residential service agency. But again, this was modeled after the requirements that are in effect for the nursing homes and assisted living as far as the time period of the first 45 days.
Okay, I'm just trying to make it as seamless as possible with what we currently do.
Yeah, and that's why we actually are very supportive of the bill, because it really does let us incorporate it into the operations for each residential service agency. So it makes it much easier to put into operation.
Thank you.
Okay, Delegate Lewis-Young.
Thank you, Madam Chair, and thank you to the individuals that have presented this really important bill. Intuitively, it just makes so much sense to me, and very much like Delegate Kelly, I personally and painfully have experienced the hardships coming from lack of training and sensitivity to those with memory loss. Can someone explain to me what these historical obstacles have been to this bill other than the obvious financial ones?
I think that would be, to me, again, really what we were looking at is just how it was to be done. The financial obstacles was very significant, but because of how the bill has been amended to allow for different opportunities of operations, and for each RSA to decide whether or not they wanted to have their employees take an online course or to have their supervisor provide the training, which is typical in many of these types of training. That's really what it was. It was just really trying to figure out the best ways for the residential service agencies to be able to operationalize it. But I think that the intent was always there. We do understand that training is necessary, especially for the population that they are serving now. Maryland's population is getting older. So we are very pleased that we were able to come to the table and get this bill hopefully off everyone's desk.
Well, thank you for your good work on that.
Thank you. And seeing no other questions of of members, I apologize. That ends the hearing on House Bill 141. And we'll now turn to House Bill 393. Thank you, everyone who testified. Delegate Barron,
Good
you're
afternoon,
up.
Madam Chair, colleagues. Nice to be with you. I'd rather be with you in person. For the record, my name is Delegate Eric Barron. I present to you a bill you've seen before. Same text, different number. House Bill 393 establishes a Maryland Office of Inspector General for Health as a separate and independent unit of government with annual reporting requirements to the legislature. The bill is modeled after the OIG for Education that we established a couple of years ago with unanimous appointment by the governor, the attorney general, and the state treasurer. This bill we passed out of committee unanimously, I guess about 8 or 9 months ago, last session. It got over 130 votes in the House. It passed out of the Senate sister committee of ours, Senate Finance, but we just ran out of time and couldn't get to second reader. The cross-file, same thing. It passed out of the Senate committee and didn't get to second reader because of the abbreviated session. The case for this bill was made pre-pandemic, and we had numerous subcommittee hearings led by our vice chair. I want to thank her for all of the work she did on helping to work out the amendments to the bill, which are now included in this version. This is the third reader version that we passed. Independence. The best practices for establishing independence for an Office of Inspector General is a appointment and removal process only for cause, a fixed term. In this bill, it is 5 years. Organizational placement that maximizes independence from the operations, procedures, and policies that the office has authority over. And so that's why we are establishing it as a separate independent unit. And funding, the office will come directly to the legislature for its funding, and it's not dependent on the Department of Health for its funding. And additionally, we included some reporting requirements so that we know what the office is doing. And we would, this committee and our sister committees would get a report annually from the office. We spent a lot of time and work on the bill. I'm happy to answer any questions and delve into more detail if necessary. I have a lot of information before you as far as my written testimony and a couple of exhibits that talk about the importance of independence of an Office of Inspector General. I think the case for this bill has only strengthened since we adjourned last session. Happy to go into that if you all, my colleagues, feel necessary, but I urge your favorable report. This will make our government better, more accountable, and transparent. Thank you.
Thank you. I'm looking for questions and I don't see any. Is there anyone who has a question?
I think Delegate Rosenberg has a question.
Why don't I see a hand?
A real hand, not a. Is that
Delegate Rosenberg, when you
Thank
want to be recognized, could you please use the the
I will.
the
I'll learn
function
it
in
there. Oh, it's
right
under
now?
reactions. Okay.
reactions. There you go. Let's put your hand up. Because then you'll keep me from making mistakes. Thank you very much.
Thank you. Thank you. Delegate Barron, just to clarify, this bill is the same bill that we passed out of the House last year and that the Senate passed as well, the crossfile. Is that correct?
Yes, the Senate Finance Committee passed this bill. We just didn't make it to the floor for second.
Okay.
Senate.
So your hesitation was not about the content, it was about how to articulate how far it had gotten in the process. So every committee and every action that's been taken is the same bill.
Right.
Right.
Yes.
Thank you. Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Barron, for bringing this bill back. Just a really quick, last year, there was some pushback, not always out in the open. I'm just wondering, are you getting the same kind of pushback against this bill that you were receiving last year, or do you feel like folks get it now?
I think folks get it. Is there the same hesitancy from the same bureaucracy? Probably, but I haven't received any additional arguments or information that would, change where I am or where we are, where we should be. And I think many of you remember hearing from the Inspector General himself, and it really only bolstered the case for the bill. Sorry, we're up from nap.
Thank you very much. Appreciate it.
Delegate Barron, let's give the department credit. At least in the sign-up sheet, they took a position of opposition. The letter that they have, their testimony, is not as clearly opposed. They chose to use the word informational. Then that's fine. But they list 5 points that they think is going to weaken the transparency and accountability of the department. Would you just take a minute or two to talk about these points to explain why you believe that is just backwards?
Yes, I'll do my best briefly. The first point talks about it would weaken the department's internal control to ensure that key compliance actions are taken by the department. In my experience, it's the supervisors and managers of an organization that ensure that things are complied with and things that are done the way they're supposed to be done with the assistance of an organizational structure that has accountability. So I don't think that they should be able to do that without an office of Inspector General internally. The second point is eliminate the ability of the fraud unit to do its job. This one is, I think, new. If you read the rest of the letter, there's nothing that elaborates on that. So without a basis, it's hard to respond other than to say that this did not come up with the Inspector General or his office. I have spoken with our Department of Legislative Affairs about the bill and our Department of Legislative Audits, all of whom believe that this bill would work in conjunction with and supplement the work that they all do and that the department does. Crippled transparency and oversight, that's just completely upside down. This would actually increase transparency and oversight. We'd know more about what's going on with the department day to day, week to week, month to month. The Inspector General, whomever that is, from year to year, would actually be able to come and speak with us about things that are going on without asking for permission. We might find things out before the Washington Post, as opposed to learning them from the Washington Post. Duplicate, I've already spoken to the fourth point about the duplication of efforts. The office, I can't speak for them, but I have met with them and spoke and communicated with them, not only for this bill, but for the previous bill in last session. And this would be complementary. These entities would communicate with one another and ensure that they're not bumping into one another. Reduce the ability, the legislative audits to resolve. I think that's kind of a repeat. So I hope that helps. But this would be very complementary to our systems that we already have in place.
So I'm going to ask one more question if it works for you and you can answer it. If you can't, just say that. I'm trying to picture how the IG would maybe have helped either with the Korean tests that we purchase, the COVID tests, or the vaccine distribution issues. Can you see a role there? Is that an example that you could explain how this would work?
So in my experience in Congress, working there, working in the Senate, and just from observation, we might communicate among one another and think, you know what, there's an issue, and maybe we have a hearing and the issue is not resolved to our satisfaction. We might then, as the chair and maybe working with the Senate chair, write a letter to the Office of Inspector General about the problem as we see it and asking for some help in finding out more information. The Office of Inspector General would have the independence to evaluate what's going on and respond to us.
Would that Inspector General have the authority to compel answers?
Yes. Under current law, the Inspector General has subpoena power and all sorts of powers and authorities that currently that office is arguably not able to fully use because they have to get permission. They're not allowed to do anything based on what they see or what they think they should be doing. They have to get permission from the department.
Okay. Thank you very much. I'm sorry to have gone on a fairly long time on that, but I really wanted to understand just a little bit better since they were kind enough to share their serious concerns. I wanted to hear your response to them.
Thank you.
Okay, I don't see any hands. I thought I did, but then I don't. So I assume there are no hands up there. Thank you very much for your testimony. I appreciate it.
Thanks, everyone.
That ends the hearing on House Bill 393. We will now turn to House Bill 368, Delegate Bagnall. You're muted. Excellent.
Thank you, Madam Chairman. And I think my panel is being let in right now,
Okay,
but I'll go ahead and start.
that'll be fine.
Thank you, Madam Chairman and committee. For the record, my name is Delegate Heather Bagnall. Now, we have heard a number of bills on dental health in this committee because it is so critical to long-term health. But many Marylanders still do not obtain regular dental visits, which can lead to serious problems and long-term negative impacts on physical, mental, and the financial health of our Marylanders. During the COVID-19 pandemic, the number of Marylanders regularly visiting a dentist has declined even more, despite intensive sanitation efforts by oral health providers, and has revealed the urgency of taking action. HB 368 would establish a task force on oral health to study the barriers to dental health care in the state of Maryland. Understanding these barriers and building on the work done by the Maryland Dental Action Coalition and the Health Department's Office of Oral Health will allow dental practitioners to better develop and expedite plans to ensure that all Marylanders can receive good dental care before they develop serious problems. You will see support from a number of stakeholders in your committee testimony, and there is no opposition. I'm asking for a favorable report. Please note there are two amendments in your packet. They are technical, and I would like to cede the remainder of my time to Dan Doherty from the Maryland State Dental Association.
Okay, so we'll give him an extra minute. And this is going to be a technical challenge for staff. We'll give him 3. Oh,
You want me to begin?
Go for it. Please begin.
Okay. Madam Chair, Madam Vice Chair, members of the committee, I'm Dan Doherty. I'm testifying on behalf of the Maryland State Dental Association in strong support of House Bill 368. I think we need to look quickly at the history of dental care, particularly through Medicaid and the commercial side. In the 1980s, the state of Maryland eliminated adult dental Medicaid. And until just recently, when a pilot program was adopted, Medicaid recipients who were adults received no dental care. We saw an increase of infections, an increase in loss of teeth. And even though we were in the mean level of incidence of oral cancer, we were at the top of deaths due to oral cancer. We had problems with pediatric dental care during that period because the reimbursement was so low. The dentists who participated had to subsidize the care given. It cost them more than the reimbursement to provide the care. Great efforts have occurred since then. The CHIP program and the enhancements to it, the O'Malley administration increased reimbursement for pediatric dental care. Other legislation and the actions of MDAC to increase access for those related to the pediatric dental care recipients and their families have also occurred. We've established Mission of Mercies to reach out to the poor people and annually give millions of dollars of care to thousands of patients. But this has been piecemeal and it's been scattered improvement. We still have a problem with people not receiving care, even though we are the 9th highest per capita dentist to population state among all 50 states in the District of Columbia. Even though 68% of children see a dentist under Healthy Smiles in the course of a year. There are many barriers to the care. Some we know and some are unknown. We're aware of cost factors, anxiety, office hour that are inconvenient. But there is so much more, and it's all interrelated and overlapping. It's time for us to give a comprehensive attack and review of this issue. We need to do it comprehensively. We can't do it piecemeal. It's time to move forward and to develop comprehensive reform. This task force represents a broad spectrum. It is chaired under the amendments by the Deputy Secretary of Public Health Services and the Dean of the Dental School. There is a real representation of consumers, advocates for the poor, organized dentistry, regulatory bodies, MCOs. This is what we need. The fiscal note is minimal. I would urge a favorable report.
okay. I'm going to make an announcement here before we move on to the next witness. I see several members have removed the video part of the Zoom. We are all required to be present, not just have our computers turned on. So if those people don't sign back in, we will bounce them out and they will be able to come back anytime. I just want to make sure that we're complying with the House rules. Thank you for that. Okay, next I have Charles Doring.
Thank you. Thank you, Madam Chair, Madam Vice Chair, members of the committee. Thank you for the opportunity to testify today before you in support of House Bill 368. My name is Charles Doring. I'm a general dentist in Rockville, Maryland, and I'm on the medical staff of several nursing home facilities in Montgomery County. I'm also the Legislative Affairs Committee Chair for the Maryland State Dental Association. I'm a member of the Dean's faculty at our dental school, the University of Maryland School of Dentistry. One of the core values in the American Dental Association's principle of ethics is beneficence, or doing good. I, like many of my colleagues, participate in community outreach programs like Mission of Mercy, Maryland Foundation for Dentistry, and Maryland's Medicaid dental program, the Maryland Healthy Smiles program. Despite these many forms of outreach, there are still communities of Maryland that go without dental care for a wide variety of reasons. House Bill 368 calls for many parties of interest to study the particular barriers to dental care and make recommendations back to this legislative body. The goal, to give every Marylander the ability to have a dental home, a home that speaks that individual's language, flexibility and access, and has the ability to participate in a Medicaid program that offers preventive care to the patients that they require without restrictions. The issues of access to dental care are multi-layered, intertwined, and complex. They cannot be teased out and studied individually. To give you an example of complexity, let's look at the perspective of dental students and recent dental graduates. According to the ADA's Health Policy Institute, United States dental schools enrollment is surging with over 25,000 pre-doctoral dental students enrolled last year, the highest enrollment ever. In the year 2000, the US had 54 dental schools. Today, there's 67. In order to accommodate diversity of the general population, dental schools are training a wider diversity of students. At University of Maryland School of Dentistry, 24% of the students come from underrepresented minority, with 13% African American. 52% are female. That's great news. According to the University of Maryland of Baltimore, in last year, 2019, dental students graduated with an average of close to $250,000 in debt. That's just dental school tuition, the highest debt of all University of Maryland professional schools. And it's even 30% higher than the debt for medical students. The staggering debt of our young dentists clearly affects their practice choice and location. The tendency is to migrate to where the population of patients are who can best afford care. According to April 2020 data from the U.S. Health and Resources Services Administration, 59 million Americans live in dental health professional shortage areas. Collectively, we need to come up with strategies that provide long-term incentives to have dental team members work in an equilibrium where everyone has the ability to and understand the importance of quality dental care. This task force will look at this and many other methods to achieve our goal. For these reasons, I ask for a favorable report on House Bill 368. Thank you.
Thank you. Thomas Beckett.
Thank you, Madam Chair and Vice Chair. Good afternoon, everyone. I'm Tom Beckett, past president of the Maryland State Dental Association and currently a vice chair of the Legislative Committee. For the past 6 years since my retirement from full-time active practice, I've spent many hours here in Annapolis as a volunteer advocate for my profession. Many of you got an email from me, and I think everybody should have gotten an email from me yesterday. It has my contact information, so if you need to reach out, feel free to do so. I speak in favor of House Bill 368, Task Force on Oral Health in Maryland. Over the past years, many attempts to change and make changes in oral health have taken place in a piecemeal approach. Now it's time for a comprehensive study. An analogy could be like getting a complete physical, taking stock of the vital signs, getting blood work, checking the reflexes, checking the vision and hearing, and perhaps even a look in the mouth. Necessary radiographs and referrals to specialists, all of this to make a decision for the appropriate treatment, such as medications, surgeries, diet, and the old bad one, exercise. This task force is that methodology to look at oral health, find the good, the flaws, the failures, and propose solutions, be it in rules and regulations, new laws, or reallocation of resources. I want to thank you for your consideration and a favorable report for House Bill 368. Thank you very much.
Thank you. Next witness is Matt Celentano.
Good afternoon, Chair Pendergrass, members of the HGO Committee. It is my pleasure to be before you today to be supportive of a bill. It's not going to be a trend, but thank you for letting me kick off my 2021 legislative session in support of House Bill 368 on behalf of the Alliance of Maryland Dental Plans and the League of Life and Health Insurers of Maryland. Maryland has made tremendous strides in ensuring healthcare and oral healthcare access in the past decade or so. I think you are all very aware of it. And we've made tremendous strides since the tragic death of Diamante Driver, but we still have ways to go. We've done a really great job in making sure that there is access for children, but we are still lagging badly with adults. This commission is sort of the next logical step to make sure that we have a chance to discuss the best ways to extend coverage and make sure that every Marylander that needs access or wants to have dental coverage has a path to do so. Thank you so much to the sponsor for bringing in the bill and for including our amendment to add a dental plan organization to the commission. We hope that we have the chance to serve on that commission. And thank you so much. We urge a favorable report on House Bill 368. Thank you.
Thank you, Matt. And the fifth witness is Janet Yelowitz.
Hi, good afternoon, and thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Dr. Janet Yelowitz, and I'm a full-time faculty member at the University of Maryland School of Dentistry. My primary activities involve didactic and clinical training of dental hygiene students on how to manage those who are medically compromised, have developmental disabilities, are cognitively impaired, or frail elders. Adults, people with disabilities, and the elderly are often faced with a wide range of barriers to receive care. Without appropriate care, they are at increased risk of systemic health problems and higher insurance rates. We know that those who receive routine dental care are physically healthier and have lower medical care costs, yet we don't offer this possibility yet. The state will benefit in both healthcare and insurance costs from a fully implemented quality dental program for underserved and underinsured adults. To get this accomplished, we need to pass House Bill 368. This is a big step in the right direction. Recently, a program was developed to address the dental needs of a small group of individuals covered by Medicare and Medicaid. The coverage in this program includes a little bit of prevention, extractions, restorations, and stops at age 65. While a good start for those enrolled, opportunities to receive preventive and routine dental care are limited in the state. For students here who are interested in going into dental public health programs, the possibilities for them to impact a larger population often resides in other states. Approving this bill will be a great first step to changing many lives. It's not easy or quick process and requires expertise and wisdom. The bill proposes members who are aware and will ensure that the plan is comprehensive and appropriate. I ask for a favorable report on House Bill 368. Thank you.
Thank you. Are there questions of this panel? I'm seeing none. I spoke with someone representing some of the dentists. I'm not sure that it was official or unofficial, and reminded that person that we generally don't do task forces. So I'm going to hope that there's another way that we can find to help do what you want to do through a vehicle that's not a task force, but I will trust my subcommittee chair to do the best that can be done to make progress on this issue. And we thank you for your very good testimony today. That ends the hearing on House Bill 368.
Sorry, Chair Pendergrass, I think Delegate Hill has a question.
Oh, well, now you do have a question. I'm sorry, I didn't see that. Was it there and I missed it?
I think I was a little late because I'm on these multiple screens and still trying to figure it out, so I apologize.
That's fine. I just wanted to know if it was you or me.
Yeah, no, it's me. Thank you.
Okay.
Thank you, Madam Chair. The question I have, I read the department's information sheet, similar to the last bill. And again, they're talking about redundancy. And obviously, if it were redundant, we'd have a solution by now, as Delegate Bagnall has said, and I'm not sure whether she's the best one to answer, Mr. Doherty or someone else. How do we get an answer? How do we stop this from being, you know, a repetition of what we've done before? Does that make sense? Why is it going to work this time? Where are we going to come up with a solution?
Delegate Hill, there is a lot of work that's been done before, whether it's from the Maryland Dental Action Coalition, the Office of Oral Health. That body of work is going to be reviewed by this task force as part and parcel of what their investigation is. If it is still valid, they're not going to duplicate it. They're going to use it as reference and then go into other areas where there's a complete paucity of information and take new information with old information, modify things from the past that need changing, and hopefully come up with a broad solution.
So is there, I understand from the chairman that this is not likely to be a task force. Is there any reason that there's not a mandate that they produce a solution, that they produce, you know, a plan on how we move forward and address the goal which this body has stated is a goal of ours over and over again?
Delegate, I think that it gives clear direction there to look at the problem, make a report and recommendation. We did not feel in looking at a drafting of a bill that to mandate a particular course was in fact where we wanted to go. We did not want to tie the hands of the task force to take a path directed by the statute, but rather be given goals to accomplish, and based on the evidence they gather, go towards that goal.
Okay, thank you very much for your testimony.
Thank you.
That ends the hearing on House Bill 368. I know that the subcommittee will take a good look at this, and hopefully the health department will be in the room and a part of the conversation, and maybe they'll have some constructive suggestions, because that's where the decisions lie until we really have to get into it. So thank you. House Bill 390, Delegate Johnson.
Thank you, Madam Chair, and thank you, committee. For the records, Delegate Johnson presenting House Bill 390. This is a bill that we heard last year. Last year, it was Bill 1277, and it requires the University of Maryland Institute for Governmental Services and Research to conduct a study on the economic impact of the closure of Harford Memorial Hospital. This is a hospital that's been in the community for over 100 years. They provide over 800 jobs, and they are moving to put up a freestanding medical facility in the next city down in along the Route 40 corridor. And I read the letter of opposition from the University of Maryland, Upper Chesapeake. And they talked a lot about the great things they were going to do in this move and all of the services they were going to provide. And it was going to be a state-of-the-art facility, and it was going to be great for the aging. And we're not disputing any of that. That's not what this bill is about. This bill is about working as a partner to do an impact study to help the city, that community that's losing their major employer, to help them come up with a revitalization plan so they can transition that property into something that would be good for that community. As we heard last year, they insisted they had done an impact study when actually it wasn't actually an impact study. It was a property reuse study, which is very limited in the scope of what information it provides. The city needs to know where they are as far as what they need to do to bring in a major development. There's also someone from the Community Housing and Development from the state working with this project. They need to know what we need so they can see how they can help us. And honestly, the hospital needs to know. And with all of this, if they can help the partners work together, it will help them market their property to a developer. So this bill is about being a partner and a transition to help a community backfill the loss of their major employer in that community. And if you look at the letters of support, it's coming from the mayor and council, the city council, county council, economic development, chamber of commerce, realtors association. So all of these folks understand the need to be partners in this project. And my hope is that working with Upper Chesapeake and University of Maryland, that they will come on board and help be one of the partners in this transition. The chairman last year requested and suggested strongly that we meet this summer and try to work this out. We were not able to meet with the CEO of Upper Chesapeake. They were busy modifying their plans for the new hospital, but we did meet with Cushman Wakefield, who is heading up this project. And I don't know if my co-delegate from the district is in, but I was going to defer some of my, if I could defer the rest of my time, Madam Chairman, to Delegate Lasanti.
Delegate Lasanti.
Thank you, Madam Chair and members of the committee. Community redevelopment of an institutional use is a very, very complex process. It requires multiple partners. It requires technical assistance and a tremendous amount of financial resources. Delegate Johnson and I have worked very, very hard over the last couple of years with all of our partners locally and at the state level to make sure that redevelopment of this site that has been in use for over 100 years has been successful. And we've gone through 3 phases of this. One phase was done by Upper Chesapeake to do a commercial real estate study to look at the highest and best use of that particular site. The second phase of that was a bond bill that Delegate Johnson and I did and was matched by the city of Havre de Grace to look at a planning process for redevelopment. And we are working on that in partnership with the Department of Commerce and Cushman and Wakefield, who did the highest and best use study for Upper Chesapeake. Now, HB 390 is the missing component. This is the piece that allows implementation of all of the planning documents. In order for a municipality to plan for redevelopment, they need to understand what their infrastructure looks like. And that's what this bill is about. It helps us really get down into the dirt, if you will, to figure out what needs to be done to our infrastructure so that commercial redevelopment of this 9-acre site that's critical to our downtown can be redeveloped. So the purpose of this bill is just a partnership, and we ask for a favorable report on this bill. Thank you.
Thank you. With that, we're going to move to witnesses, starting with William Martin, followed by Erica Quisenberry.
Madam Chair, if I may, I think Mayor Will Martin wanted to go last, if that's okay.
That's fine. Start with Erica Quisenberry.
Good afternoon, Madam Chair, Vice Chair, and honorable members of the HGO Committee. And thank you for this opportunity to address you in support of House Bill 390. My name is Erica Quisenberry Sturgill. I'm Director of Economic Development in Havre de Grace. Previously, I was the Maryland Main Street Program Director for the Bel Air Downtown Alliance, and in 2005, the Base Realignment and Closure Coordinator for Cecil County Office of Economic Development. Havre de Grace is built on a bedrock of uncommon volunteerism and community activism. This was profoundly evidenced when a group of volunteers, delegates, senators, and the Treasurer of Maryland gathered in 1911 to found a hospital here. In 1912, the first patients were admitted to what became the Havre de Grace Hospital. The name changed over the years, but the foundation of community remained. And the hospital, as it stands today, remains on that original lot of that hospital, a community built and funded 108 years ago. Now that property expanded to support community growth from a 21-room Victorian to the brick edifice of the New Deal will change dramatically. Those 9 acres that once served an entire county and parts of Cecil County will, for the first time in over a century, have no defined purpose. The economic success of Havre de Grace was and is intrinsically tied to that of our community hospital. Our first 20th century building boom came in 1917, 5 years after the hospital opened, wherein all the advertising for new homes avowed 2 things: proximity to APG and a world-class hospital in Havre de Grace. That narrative didn't really change during the 20th century building boom and didn't change during the Great War, but continued with the building boom that began in 1938 and the 524% growth rate of Harford County between 1950 and 2000, and right through to Bully Rock and the BRAC 2005 recruitment of Fort Monmouth employees, where again, proximity to APG and our hospital were the constant driving factors of our narrative. It's not merely the diner and the flower shop that must brace for the closure, but the businesses who established in Havre de Grace because of the hospital. Medical supply, 5 pharmacies, assisted living, treatment centers, multiple low-income senior housing projects, prosthetic manufacturers. Anecdotal evidence of a family doctor closing shop, a pediatrician relocating after 20 years to Delaware for continuity of care, a cardiologist office becoming a craft store is not fact-borne data to help us steer the course for our city when the hospital is gone. Havre de Grace is asking for the same guidance, collaboration, and expertise that was brought to bear over a century ago by state and local leadership to sustain a strong community in the midst of a healthcare paradigm shift. We're here because the city of Havre de Grace will be significantly impacted when a 279,000 square foot hospital shuts down and the largest employment center within our communities for sale. It took 2 decades to find a purchaser for a 140,000 square foot building in town. A 400,000 square foot tenant was vacant for a generation before finding an investor just this year. We simply cannot sustain this type of vacancy in our downtown. Havre de Grace has worked tirelessly to recruit and retain business. We revitalize our Maryland Main Street community and enhance our designated arts and entertainment district. We acknowledge the University of Maryland is changing that district, and we ask the resources of such an institution dedicated to maintaining and improving the community to continue to serve us 5 miles distant to be an active part of developing a positive path forward in collaboration with Havre de Grace. Thus, I ask for a favorable report on House Bill 390.
Thank you. Our next witness is Shane Grimm. I'm guessing this is not going to be a woman.
Thank you, Madam Chair, and the honorable members of the Health and Government Operations Committee. I'm here to speak on House Bill 390. My name is Shane Grimm, Director of Planning for the City of Havre de Grace. I'm a certified planner through the American Institute of Certified Planners, and have been in the field of planning and zoning for 20 years. I'm here to speak with you today about the importance of House Bill 390 and why passage of the bill is vitally important to the city of Havre de Grace. Our city is home to approximately 14,000 residents, with thousands more in the greater Havre de Grace area that visit downtown to work and support small businesses. Arguably, Havre de Grace is also the cultural epicenter of Hartford County, supporting local artisans and craftsmen, such as those famously engaged in the centuries-old art of wood duck carving. Havre de Grace has one of the lowest crime rates for a city of its size in the nation and was the second safest city in Maryland in 2019 due to the efforts of the current administration and our chief of police. The new state-of-the-art Havre de Grace Middle High School opened this year and offers innovative learning environments and programs to prepare our students for the future. We're consistently ranked among the top small cities to live in Maryland and the country due to our small town charm, ambiance, and excellent location along the eastern seaboard, among other positive attributes. The city has all the requisite ingredients in place to continue its ongoing renaissance and become the premier small city on the East Coast. Population trends over the past 20 years prove that Havre de Grace is a desirable place to live, work, and play. Since the year 2000, there's been a 25% increase in the population of the city. Clearly, this historic city at the head of the bay that almost became the capital of this great nation has the, quote, it factor. And we anticipate considerable population growth over the next decade, with dormant developments coming back online and newer developments breaking ground within our current borders. The principles of smart growth are alive and well in Havre de Grace. With respect to the Hartford Memorial site, we are seeing new infill development in the immediate area around the hospital and many renovations of existing homes. The city supports and encourages the renovation of existing housing stock, one of the core principles of smart growth. New and renovated home prices have steadily increased, with the most recent sales being well over $500,000. There's also been an 8% increase in assessed values of residential properties and a 2% increase in commercial properties, per a recent ESTAT report. The Hartford Memorial Hospital parcel represents a total of 5 acres in the heart of our historic downtown, with the main hospital parcel situated on approximately 1.5 acres along the iconic tree-lined Union Avenue. The future of the hospital site, located in the Old Town Revitalization Area, as identified in the city's comprehensive plan, is crucial to our continued revitalization efforts. Presently, the hospital represents the anchor to a medical corridor that supports numerous medical practices of varying specialties. The plan did not contemplate the hospital leaving the city when it was adopted in 2010. However, it did contemplate the possibility of a new hospital. The plan contains specific recommendations that are still relevant today and must still guide the redevelopment of the hospital site to be compatible with existing development and our vision for the future of our city. These recommendations are: continue to support the mix of uses within the Old Town area of Havre de Grace, to include offices, residential, and limited commercial, strengthen the medical corridor as a presence within the city, develop design guidelines for new construction with the National Register Historic District in mind, so that new buildings are in keeping with the historic character of the Old Town area, work with the state of Maryland and local nonprofit entities to develop opportunities and incentives for home ownership, continue to work with property owners regarding new development in the older areas of the city so that improvements are compatible with existing structures and the surrounding context. In closing, the city of Havre de Grace is continuing its renaissance that began in the early 2000s, and an influx of newer residents are seeking out this charming city to call home because of its ideal location along the eastern seaboard, its diversity, its history, and its culture, and not to mention its people. We believe in the wake of the pandemic, more people will be seeking out Havre de Grace as an alternative to larger urban areas. I urge support for House Bill 390 to ensure the redevelopment of the hospital site is compatible with the city's comprehensive plan, smart growth principles, and our desire to continue revitalizing the Old Town area, encouraging home ownership and honor and respect this historic city by the bay. Thank you.
You're welcome, but I'm going to take this time to remind people to ask their witnesses to unless otherwise directed, to speak for 2 minutes. That was 5 minutes. That was not really the path we plan to take in future. I did not want to interrupt you. Our timer system is not working in a way that would be ideal. We're going to have to work on that. These technical difficulties will take time. But I'm going to ask members, please ask your witnesses to follow the rules. The guidelines are listed on the website and you all know what they are. Thank you. Edward Garano.
Madam Chair and the honorable members of the Health and Government Operations Committee. My name is Ed Garono. I'm Vice President of the Main Street Alliance, which represents the businesses here in Havre de Grace. I've been a realtor in Harford County for over 30 years. I moved to Havre de Grace 6 years ago when I invested in a commercial building with a restaurant and 2 apartments. We also rescued an old Victorian home in town, 2 blocks from the hospital where my wife and I live. I was asked to comment on the impact to businesses and home ownership and the importance of having a study completed to quantify these impacts. We feel it very important that the study come from an independent firm not working for the interest of Upper Chesapeake. When the largest employer in any town is closed down, you can imagine the ripple effects on the surrounding businesses like restaurants, stores, services, and banks, the places where those employees supported every day. The employees are transferred to new facilities. These businesses are then left behind. The effect on property values and the resulting effects on assessments are a great concern to homeowners, and I'm sure to municipal budget folks as well. Prospect of what will replace the hospital has everything to do with the effect on property values. 9 acres in the heart of a town is a big hole to fill. We hope the study will give businesses and citizens some idea of what to expect. The impact of the closure of Harford Memorial will have on businesses, employment, and property values has not been studied, and many unknowns remain. This bill's passage would give the city the knowledge it needs to understand these impacts and prepare for them. So on behalf of the businesses in Havre de Grace, we urge the committee to give the bill a favorable report. Thank you.
Thank you very much for your testimony. Last witness is Donna Jacobs.
Chair, I think we were going to go back to William Martin.
Oh, I'm sorry, William Martin. You're correct. Thank you for your help.
Hey, not a problem. Good afternoon, Chairman Pendergrass and honorable members of the committee. My name is William Martin, the mayor of the city of Havre de Grace. I appreciate your time, and I will keep it under 2 minutes, I promise, Chairman. So I really appreciate what Delegate Lasani and Delegate Johnson have done with moving this bill forward, and I appreciate the witnesses in favor of this. I'm just going to be very blunt, just for the sake of time here. As it was said, the hospital was built over 100 years ago in the city of Havre de Grace by citizens, not by a company, it was by citizens. This city has grown around that hospital. Generational families have moved here because they worked at that hospital. Our zoning laws have been created based on that hospital, and many of our businesses and doctors' offices and ancillary businesses as such have grown around that hospital. We're not a city of many buildings, we're a city of a building, and that is the building, huge building in our city that sits on 9 acres of land. When that hospital leaves, it's really going to create a void. And one thing I can tell you, we're not asking the city, or we're not asking the state of Maryland to spend thousands of dollars on a study that's going to end up in some bureaucrat's desk drawer and said, hey, we have a study done. We need this study. We don't have the political clout in Harford County that University of Maryland Upper Chesapeake has when it comes to getting all the things they need. I'm asking help in Annapolis. We need this. I mean, we've gotten the short end of the stick on a lot of things. That's another story for another day. I ask kindly and respectfully that this committee reports favorably on this report to help our city of 15,000 people move forward with this great big void that's been part of our city for the last 100 years. Everybody, I appreciate your time. Thank you very much for letting me speak. And thank you all for your services, Maryland citizens, under these adverse conditions. Thank you very much.
Thank you, Mr. Martin. Donna Jacobs. Oh, wait, you know what? Let's just have Donna Jacobs and then we'll ask questions of both sides of this issue.
Thank you,
Since there's
Madam
only
Chair.
one witness.
Madam Chair, Madam Vice Chair, members of the committee, Donna Jacobs for the University of Maryland Medical System. Thank you for the few moments to speak to you on behalf of Upper Chesapeake Health. This bill is a bill that was before the committee last year, and I would say it's essentially in the same format as you saw about a year ago, not a little bit has changed. Upper Chesapeake's commitment then was to work collaboratively with the city of Havre de Grace, and that commitment remains the same today. I would submit that this is a local issue and one that the hospital has taken seriously. At the heart of the matter is, as was mentioned right at the outset by Delegate Johnson, Upper Chesapeake's plan to modernize and expand healthcare in Harford County through the conversion of Harford Memorial to a freestanding medical facility, to building a psychiatric specialty hospital, and expanding some services in Bel Air. At the heart of it, or what generated this interest in the beginning in this bill, was about the site, of course, at the hospital. Vis-a-vis that property, Upper Chesapeake engaged Cushman and Wakefield to conduct a comprehensive property analysis of the hospital site and evaluate the best and highest use. And it was conducted by or led by Dave Baird, the managing director. And again, he spoke to you last year. They did a 9-month study. It was a comprehensive review of the physical property itself, an in-depth review of the economic conditions, the demand drivers in the area. They spoke to a number of key stakeholders, leadership, elected leadership, faith leaders, business leaders, community members. And this was all in addition to the very careful and prescriptive requirements that this committee worked so diligently on when converting to an FMF. At the conclusion of this study, which was way back in 2017, it was determined that the property was essentially obsolete and non-functional, but it could contribute to the potential redevelopment in the community and enhance the quality of life in Havre de Grace. Since then, there have been myriad conversations about this facility, and it's true that Vice Chair spoke to this issue last year and said, please continue your conversations. COVID intervened, and then those conversations did resume in the fall. And that's continued. Mayor Martin, in October, there was a meeting. Mayor Martin followed up last week. Mr. Baird, on behalf of Upper Chesapeake, responded. There's been correspondence, including with Mr. Grimm and others. Cushman and Wakefield is testing the market. There's a soft test. And it's a little bit perplexing, really, why we're here again talking about this issue. And Mr. Grimm summed it up, I think, very well. It's a waterfront property. It's attractive. The city is amongst the top small cities to live in the US. It's got the ingredients to continue. It has an it factor. So all of those things are playing well into the fact that people and developers are interested in this property. And if we allow it, this can just move forward. And maybe it's not as much as an opposition, but really informational, because the conversations are being had and the work is being done. And the city is poised to do very well when this hospital is closed.
Thank you for your testimony. Appreciate it. With that, let me see if there are hands in the. We'll start with Delegate Kipke and we'll move on to Delegate Krebs. I can't hear you.
Got it. Thank you, Madam Chairman. Donna, you're right, this is a local issue, so I haven't been following it as closely. Is it correct that the ship has sailed, that there's not going to be a hospital there? It's going to Aberdeen, and what we're presented here is just, like an economic evaluation of the property that would,
And the community.
I'm confused as to what's going on here.
I think that's right. And the ship has sailed is probably an apt description. Upper Chesapeake worked for several years to try to relocate. We can't use that facility. It's aged. It simply would not function well as a hospital. It's not what you'd want to maintain in that community moving forward. They tried to relocate in Havre de Grace, and we were moving down the corridor, if you will, and then a number of unexpected costs were added from the city, and I'm not intimately involved, but I have general understanding, and property in Aberdeen became available. So yes, that's right. The FMF, the freestanding medical facility, will now be built in Aberdeen, and then this property will be vacated. That is correct.
Okay, and that's happening. The ship has sailed, right?
The ship has sailed, yes.
Okay, thank you, Madam Chairman.
Delegate Krebs.
Thank you, Madam Chair. And I remember this bill from last year, and I thank my colleagues for their passion about their local community, Delegate Lasanti and Johnson. I understand that. But I guess I have a question maybe for the mayor, or either the mayor or Mr. Grimm. And it has to do, this obviously is an economic impact statement for the locals. And I guess I can't understand why the local planning and zoning authority or the county does not have some authority through local zoning or doing an economic development impact study on their own, why is that not available? I know a year has gone by. Why can't those tools be used through planning and zoning or a local economic impact study by the county or the town?
I would ask whichever of you is best qualified to answer the question to be the person to answer the question.
Madam Chairman, I can answer the question. Yes, there was several years ago a study done by a company called Cushman and Wakefield. But the study, and one of the reasons why we're asking for this is the study was never given to us. We've seen slideshows. We had a brief meeting in October where we had a slideshow, but the thumb drive was protected with lock and key. We're a city of 15,000 people with almost 20,000 people in a surrounding area. We'd like to see that study, but the study's not all inclusive. There is so much at stake here with that building. As I said earlier, we're not a city of many buildings, we're a city with a building, and that's going to go. And as I said earlier, it is a whole myriad of backstory to this, but we've really been left out of a lot of the conversations, and we're only asking to be brought to the table and be given a chance to make sure that whatever happens to this 9 acres of land in our city fits within our comprehensive plan, because we're a historic city. We're a city that's finally turned a corner and we're having some kind of economic gain in our city. We have a new high school that just opened up this year. So it's very important that we be brought to the table. And as I said earlier, this study is not about a bureaucratic study where we can stick in a drawer. This is something that we really, really need to get done. It's very important, and we feel very important about it. And that's why Lasani and Johnson brought it back up.
No, and I thank you. I thank you. You're one of the coolest small towns in America, and so are we in Sykesville. And we had a similar situation with our a former state property, Springfield Hospital. We had the same situation, but we sort of took it over with local planning and local economic. That's why I'm asking, because it's sort of precedent setting, because there's so many. We have state properties that are abandoned as well, and it's a little bit of a precedent. But I appreciate your concerns of your small town, and I know it's an economic driver. So thank you for that answer.
Thank you, Delegate Krebs.
Okay, let's remember that when we ask a question, it's intended to be a question, not a chance to voice a speech. I see that Delegate Johnson has a question.
Thank you, Madam Chair. The question is for Donna. In your letter, and I want to make sure the committee is clear about what these studies do. You guys did a reuse study on just that property, and we are asking for an impact study. Can you explain the difference, how it addresses when it comes to infrastructure, how it affects the businesses, the stores, a little more in depth so the committee can understand the difference?
Well, you would not want me to try to begin to give those explanations. Certainly, that's part of the reason why Upper Chesapeake has engaged the brokerage firm of Cushman and Wakefield. But it's interesting to me that in the discussions that resumed back in the fall, apparently there was quite a bit mentioned, said, discussed, shown, spoken about with regard to the development within the community, not just that property, and what it might look like. And even the mayor's letter says, we're most encouraged by your comments relative to incorporating the city's guidance and desire to shift away from highest and best use, but instead to address the citywide goals, et cetera, et cetera. And that was just on January 14th. And in response to that, Mr. Baird said, thank you for your note. This is the very next day. And for the meeting that we had with your leadership team. And we believe that by working together, we can attract investment capital and appropriate plan for the redevelopment of the important property and meet the goals of all of the stakeholders. So that suggests to me that the conversation was pretty replete and robust. Of course, and that the needs of a greater than one, if you will, could be met by the work that's underway and the discussions that are underway. And it does appear to me that if there were to be a study of the nature that you mentioned, Delegate Johnson, and I do want to thank you for our conversation earlier today, that again, that it's a matter of a local matter, and that's something that the local jurisdiction should really be working on.
Thank you.
Okay, Delegate. I'm sorry, Delegate Lasanti, you are the sponsor and you're not a member of the committee, so I'm not finding it comfortable to call on you. I don't have that in my rules somehow to include you to do that. Delegate Riley.
Thank you, Madam Chair. Yeah, two, if I could, it's two really quick questions. One, it would be to Diana Jacobs, would be the hospital. Is it clear to say that the hospital hired Cushman and Wakefield because the hospital organization and the commission is not a developer?
Oh, that's exactly right, Delegate Riley, and thank you for the question. So Cushman and Wakefield has actually been on board since the notion of a freestanding medical facility was even contemplated. So this goes back to 2016 or so, and they began work well before the Maryland Healthcare Commission rules were followed to the T, all along the way, and engaging the community and explaining what was happening with the employees and where they would be located, how they would, all of the measures that are required under the bill that you all worked so hard on. And yes, the answer to your question.
Okay. And a quick follow-up to that would be that you're not leaving Harford County. So whatever Cushman and Wakefield does on this property, and you have been totally committed. We just had a delegation meeting and committed to, the mayor and to the delegates that they will be partners in this process. The hospital is not leaving. You're, opening a state-of-the-art freestanding facility and plus improving the current hospital. So this would be, whatever you do there is going to reflect the hospital. So I would assume, as you had said and stated in many meetings, that whatever happens there in Havre Grace, you will make sure that it works for Havre Grace citizens and the citizens of Harford County. And the reuse study we just saw as a delegation, some of the prospects and what you showed us are, were beautiful, good ideas. So I have full confidence in Cushman and Wakefield, and hopefully I'm sure that you will stand by and work with the city of Havre Grace. It is a beautiful city. We all love it. We visit it a lot. So thank you, Madam Chair, for allowing me to expand on our wonderful city of Havre Grace. And thank you, Diana Jacobs, for the work that you and the hospital are doing on this. And we look forward to a great partnership. Thank you.
Thank you very much. Harford, the hospital is to the entire county. You're correct.
I'm concerned that we're veering off the question issue and onto speeches by delegates, which is not intended to be what we do with questions. That's the second reminder in this particular hearing. You don't ask a lot of questions, and I'm trying to just remind us all that we're trying all to follow the same rules, not different rules for different people. Delegate Young.
Thank you, Madam Chair. I've noticed a couple of comments saying that this is a delegation issue, but isn't the delivery of healthcare really a state issue? And so I do hear, I think I hear, correct me if I'm wrong, a rationale for support in paying for the redevelopment of the property because the delivery of healthcare is a state challenge.
And who is your question directed to, Delegate Young?
Whatever individual is best suited to speak to it. I'll let the lead sponsor determine that.
Thank you, Delegate. This is not about the level of healthcare. This is about the transition.
Hang on. That's your comments now are into a discussion between delegates and best saved for the subcommittee. Yeah, if that's it, it needs to be a witness because this is their time to speak, not our time to have a discussion.
Thank you, Madam.
Okay.
Thank you, Madam.
You're welcome. Thank you for trying to be helpful. I know you were. Okay, I don't see anybody volunteering to answer the question. I will take a volunteer if you want to do that, and if not, that will end the hearing.
I can maybe try to answer the question. Delegate Young, if I understand, I will try. So we're talking about moving a facility, converting it to a different type of facility in Aberdeen. The use of the property that remains in Harvard Grace will no longer in and of itself be about the delivery of health care. So we're talking about two very distinct things. The health care will be provided in Bel Air in an extended way, in the new psych hospital, and in Aberdeen in the freestanding medical facility. All of those transitions or new buildings, if you will, both in terms of the health component and in terms of the facility, have been guided, governed, and approved by the Maryland Healthcare Commission. What we're talking about in Havre de Grace is the property and the property that remains and the surrounds, not the building guidance or governance of healthcare per se.
Thank you for that distinction.
Seeing no further questions, I'm going to say that is the end of the hearing on House Bill 390. And
So did
what?
everything will come out all right?
I think Delegate Johnson had a question.
Oh, I thought Delegate Johnson asked his question. Delegate Johnson, I'm going to give you one last question.
Thank you, Madam Chair. Donna, you said that they did a few years ago, they did that reuse study. Do you know, did the city get a full copy of, we're talking partnerships here. Did the city get a copy of that study? I know we got a few slideshows, but did they get a copy?
I can't speak to that because I was not present, but I do know that since the original 9 months that I referred to, there was a subsequent update of that study, and that was what was discussed back in October of 2020.
Do you know if they had a copy of it?
I don't know.
Okay, thank you.
If it's possible to share a copy with the stakeholders that have been represented here, I would appreciate that because I think they would appreciate that. Thank you for looking into that for us. That ends the hearing on House Bill 390. If there are no general questions from my members about what's coming next beyond the fact that we have another meeting tomorrow at 1:30, I'll say that ends the hearing for today. Thank you very much.